Good morning, everyone, wherever you may be. I'm in Spain, so it is about 3 p.m. in the afternoon. We have people from Australia, where it is quite early in the morning, people from North America, and all over the world. We have about 100 people registered for the course today, and appreciate everybody coming. This has been a major initiative from the Scoliosis Research Society Research Promotion and Oversight Committee. I will be co-hosting this today. My name is Jim Sanders. I'm at the University of North Carolina in Chapel Hill. My co-host is Dr. Carol Weiss, who probably most of you know, who is at Texas Scottish Rite Hospital in Dallas. We have a great group of people giving some outstanding presentations today. We have selected courses or selected research throughout various phases of the research. So some are brand new or just getting started. Others are completing or have completed their projects, but they're all SRS funded. The goal for today is for people to have an oversight of what is happening in the SRS, to have some of their own research questions answered about how to proceed, how to do well, and how to succeed. And also just to enjoy the science that's going on that's being sponsored by our society, which we were very, very grateful for. This is now the third one of these, and we are very much looking forward to getting going with this today. So there is a question and answer component. Please, as we are going through the various talks, please type your questions into the question and answer format, and this will give us a good way to both to be able to keep track of what was done as well as to be able to answer the questions. We also have the goal of being able to answer questions after the meeting and having the presenters go back and answer questions for you. So if we don't get to all of the questions today during the conference, please know that the goal is to get those back for everyone to have some answers to your questions. So with all of that, I don't want us to spend a huge amount of time with the remainder of the introduction here, and we will get going on our presentations today. The first one that I would like to introduce to you is Dr. Peoria Solari, who is in the midst of a very good project on the effect of controlled dynamic spine distraction on intervertebral disc, growth plates, bone quality, and bone stiffness. Without further ado, Dr. Solari, I would like to turn this over to you.
Good morning. Thank you, Dr. Sanders, and thank you to SRS Research Committee for setting up this great symposium. I'd like to share my slides here. Okay, today I'll be talking about the effect of controlled dynamic distraction on disc growth plate. And this is an animal study which used an immature animal model. And I would like to acknowledge my co-PI, Dr. Simon Tang at Washington University in St. Louis, and Garrett Eason, which is one of the PhD students helping us with this project. We have no financial disclosure except this study was funded by SRS grant. Treatment of scoliosis in a skeletally immature patient is challenging. Hypothetically, distraction-based growth-friendly techniques spare growth plates and spinal growth. However, we have very limited knowledge of the effect of distraction on the disc, growth plate, growth rate, spinal stiffness, and bone quality. The purpose of this study was to evaluate the effect of distraction in this animal model and look at the disc size, morphology, viscoelastic behavior, and also vertebral body growth, end plate morphology, and bone density. We had 32 female mice divided to 4 groups randomly, and each animal tail was instrumented using pins, as you can see on this image, in 7th and 9th vertebral body, and distraction forces were applied using a Elizarov type of device, which was a custom made, and we used distraction forces and kept the distraction forces constant throughout the study. You can see on the X-ray the unit of the study is the vertebral body and the disc, and on the left side, the distal to the instrumented level, we use a control disc and vertebral body as a control group. We obtained weekly X-rays and biweekly micro CT scan. 4 groups. In group 1, we had distraction from 6 to 20 weeks of age, group 2 from 12 to 20, group 3 from 6 to 16, and group 4 was the sham group, which was instrumented, but there was no distraction. All animals completed the study. There was no complication. There was no weight difference between the animals in different groups. There was no implant failure or loosening. As you can see on this image, on the left lower is a micro-CT and right side is histology. There was a great osseointegration with fully mineralized lamellar bone formation around the implant size. When we look at the disc height, we had increased disc height, which was significant in the all groups, was significantly higher in the group with distraction from 12 to 20 weeks of distraction. Same thing happened with disc volume. We had increased disc volume with distraction, which was significantly higher on the same group from 12 to 20 weeks. When we look at the stiffness of the intervertebral body disc, we had increased, which was significantly higher in the group from 6 to 20 weeks, and that was 60%. Then we measure viscoelastic behavior of the disc, which is measured as loss of tangent in the curve with applied forces and displacement. And you can see here again was loss of tangent or decreased viscoelastic behavior, which was significantly higher in this same group, 6 to 20 weeks of distraction. When we look at the glycosaminoglycan content of the disc, you had decreased GAG content with distraction. This was not significant, but you can see the decreased intensity of the color. This is on the enhanced micro-CT study, which is a new technique. And you can see this decreased intensity, but wasn't significant between the groups. Then we look at the nucleus pulposus. You can see on the left side is the distraction disc. It shows increase or expansion of the disc. In the center, increased cellularity or proliferation of nucleus pulposus, which happened with distraction. When we look at the growth, vertebral body growth was affected with distraction, increase in vertebral body length, which was significantly higher in the group that had the highest distraction from 6 to 20 weeks of age. Then we look at the total volume of the end plate. Again, we had some changes here which increased, but the highest was the group from 6 to 16 weeks of age. We look at the bone volume fraction. This could be used as a measure of bone density. And you can see here, which was a loss of change in this fraction was significantly higher in this group from 6 to 16. Look at the morphology of the end plate. These changes, again, this is using micro-CT studies, a little bit newer techniques. And but you can see, I highlight here, you can see in the distracted group, this is the end plate, shows the deepening of the center of the end plate, increased pore size, and decreased bone concentration in the center. The red pictures on right below the end plate shows that increased porous size, which could be due to high turnover or demineralization of the area. It's not necessarily the decreased pore size, it's just a mineralization decrease. In conclusion, this is the first study to show the effect of distraction in a mature animal spine model. There's some prior study, but mostly on degeneration, and the goal was to target degeneration and regeneration of the disc when you apply mechanical forces. This study shows that we are able to do growth modulation, vertebral body and disc. There was no significant complication. There was no end plate fracture or growth arrest. There was some decrease in GAG content, which was not significant, but stiffness increased and viscoelastic behavior of the disc has changed. We had some nucleus pulposus expansion, which showed as could be evidence of proliferation. At this point, it's unknown for us to how to interpret this information, but it looks like it's you can interpret it as a regeneration at the same time with increased stiffness and decreased GAG content. This is really unknown that how to interpret this data. We're working on it. And this study provides a very detailed information on growth plate and disc, and could be a very good roadmap for future work. The next question we have here is that if any of these changes that's happening at this level, are they reversible or not? And if with longer follow-up, if we could see if any of these changes, first, if they're reversible, and second, what's the significance of it in the animal model, and hopefully in future we can expand it to human and pediatric patients.
This is excellent work. We have a question here, which is, first of all, it states from Dr. Igagi, it's beautiful work. One comment, this is based on quadrupedal and not a bipedal subject, such as humans or primates. How do you rectify for this difference?
Well, that's a very good question. I don't think I have a good answer for it, but that's a major issue we have with animal model. We try to find the best animal model, but necessarily, I mean, doing at some point I was even thinking about using monkeys, which are very similar, but from logistics standpoint, it's literally impossible to use something from financial standpoint and the regulatory standpoint. Doing such a thing is impossible. We try to find the best animal model we could, which is doable. It's easier to perform in the lab, and again, from regulatory standpoint in the US, that was the best model at this point.
So I will take the moderator's prerogative and ask a few questions here.
Yes.
The first is that in the world of early onset scoliosis, there's a couple of philosophies that people have. One is to drive growth, where you really push hard to try to increase it. And this seems like a very good model for that. The other is to try to keep up with growth. Do you think it has applicability to that latter model?
Well, again, very good question. Again, because a lot of things that we did study was something that was done for the first time, we couldn't, it's hard to measure the amount of growth that we are following in this animal model, and how much force to apply to catch up with the growth versus pushing it to promote growth. At this point, with this current data, I can't comment, but in future, with further work, if we can measure the growth, and for example, if you have a group that we can use as a control group and measure the growth, and maybe keep up, try to measure the forces and adjust the forces that we are applying through the end plate and the vertebral body to catch up with the growth, we can compare these two groups, and would be a very great study to see what's the difference.
We also have a question from Dr. Kelly. Great work, Poria. Do you think we can examine the opposite of distraction with this model, i.e. for tether?
Yeah, certainly. There are some studies done by Ian Stokes, who's a very prominent researcher, and it's been acknowledged even at SRS for his work for degeneration work on the disc. I don't remember the details, but he has done work on the compression in same animal model with a very similar Elizarov type techniques, but not in the setting for pediatric patient. I think it would be a very good study to look at it and see what's the effect, especially on the growth plate. Most of the studies that he has done, they're from many years ago, 15, 20 years ago, and with the recent technology using micro-CT, contrast-enhanced micro-CT, and the new histology techniques that we have, I think would be a very valuable study.
Do you know what physiologically is going on that's making these changes? You notice the increased cellularity within the nucleus pulposus, you notice the changes, but there's clearly some factors that are going into making this more stiff. Are you getting fibrosis occurring with this? Is there osseous formation, or is it simply you're losing your proteoglycan, and therefore it's going to end up being stiffer in the end?
I think there are a couple of things that are clear. First, when it comes to the growth, the bone, we can modulate the growth. So the bone, it's very clear that the vertebral body height increases. That's very clear. And the fact that there was no complication, that's a good thing, that we can promote the growth. So when it comes to the bone, a lot of things are more known for us because we have been working on it for a longer period of time. And then the next question is the disc. When it comes to the disc, I think we have a lot of unknowns here. And I'm going to share again this screen, if I can share it again. I can share it, but so if you look at the nucleus pulposus with increased proliferation, the first thing comes in mind, increased size. Maybe we're increasing the size, and nucleus pulposus proliferation is going to be increased cellularity. But at the same time, we have the stiffness and decreased GAG content. So you can interpret this that okay, we are causing degeneration from on one side, but at the same time, you can see the proliferation in the nucleus pulposus. It could be an adaptive measure that cell and the disc is taking over time to adjust to the effect of distraction, or could be regeneration. At the same time, you can see the stiffness, which is very consistent with law of diminishing return and things that we know in early onset of scoliosis, increases stiffness, and we don't get the correction we get. Again, at this point, it's really hard to interpret those data, but some of it's consistent with degeneration, some of it's with regeneration. Well, what we were thinking and discussing, potentially if we continue to study more, because in some of this data, you can see in the group that continue to have the distraction from 6 to 20 weeks, some of them had more time to adjust, and you can see those changes that initially were significant, they start to disappear. So maybe longer study, and if you give the animal model more chance over time, that they're going to adjust and the stiffness is not going to be the same, or the GAG content is going to come back to normal. Could be a process that, okay, increase in disc height, increase cellularity, but GAG content ratio decreases, but over time, that proliferation, it's causing the GAG content to come back to normal with a delay, which is the adaptive measure from in the cell at the level of the cells.
Sorry, I want to thank you for your presentation. Thank you for the questions. I hope that the questions were specifically answered. There were a couple of others that went along the same lines as the ones you have answered. I'd like to move on now to our next presentation, which is going to be by Dr. Craig Birch on the postoperative pain control using local wound infiltration in adolescent idiopathic scoliosis, a randomized controlled trial. Dr. Birch, welcome, and I'll turn it over to you.
Perfect. Thanks so much for having me. Get full screen. So thanks for the opportunity to talk about our ongoing research. We are going to talk a little bit about postoperative pain control using the local wound infiltration, adolescent idiopathic scoliosis. Perfect. All right, so no disclosures. We're going to talk a big thank you to the other members of the study team. Talk a little bit about the background, our specific study, and then very preliminary results because it's still a work in progress, but then where we're moving in the future. So postoperative, perioperative pain treatment and management postoperatively has been a big issue recently, especially with the opioid crisis that's ongoing both in the US, but also in other countries. So it's a big topic more recently. There's been a lot of literature from other subspecialties talking about the use of local injection as a method of controlling postoperative and perioperative pain. So a lot of recent studies, and then a big boom recently if we look at the number of publications talking about local wound infiltration within orthopedics, but really not too much about the spine literature specifically within AIS. So our specific study is looking at, it's a prospective single-center, double-blinded, randomized control trial with 2 arms, one being an injection with 0.25% bupivacaine medication with epinephrine, and then the placebo arm being an equal volume of injectable saline. We had fairly strict inclusion-exclusion criteria to keep groups as consistent as possible. with an inclusion criteria of diagnosis of AIS with a curve greater than 50 degrees, 45 in the lumbar spine, meeting surgical magnitude, having an index procedure, which is a definitive fusion with an age of 10 to 18, and exclusion criteria of recent opioid usage within 30 days of the time of surgery, having a prior spine surgical intervention, an underlying mental health diagnosis, and then obviously any prior adverse reaction to a local anesthetic. Our primary aims are to assess the impact of the local wound infiltration on postoperative pain scores, as well as on postoperative opioid consumption, which was measured by morphine equivalents per kilogram. And then also had some secondary aims looking at having patients complete a more longer term postoperative pain log, time to first mobilization postoperatively, and then the duration of hospital stay after surgery. The recruitment process, we had our research coordinators screen all surgical patients to see if they met both inclusion and exclusion criteria. And then there was a clinical discussion both with the operative surgeon as well as the research team at the time of the preoperative visit. For randomization, we used the envelope method. This was all managed by the research department so that the surgeons were kind of excluded from this process. And then that envelope, as well as the order for the medication, were then taken to the investigational drug pharmacy that we have at the institution. The pharmacist would then open the envelope, see which arm of the study they were being randomized to, and then would deliver a syringe of the appropriate weight-based amount of volume of either medication or injectable saline that was delivered to the operating room and labeled as the trial medication. And then the infiltration was performed by the surgeon at the time of closure. And so we tried to come up with a method that was very reproducible. So we did not focus on a superficial skin injection. We also did not focus on doing an attempted deep block of the erector spinae, which has been described kind of previously. The real goal was to say we're going to inject this in small dose, small volume injections at evenly spaced intervals throughout the paraspinal layer at the time of the fascial closure, which is something that's relatively reproducible because there are 4 operative surgeons in the group. We do have very preliminary results, but we don't have unblinded results. So we'll talk a little bit about some of the difficulties that we had with the randomized control trial getting off the ground. One of them was that there was about a 9-month-long national shortage of bupivacaine with epinephrine. And so we wanted to keep things consistent, have the same manufacturer, ideally have very similar lot numbers to the medications. And so we wanted to wait until we could purchase the entirety of the drug volume that we would potentially need for the study, because we didn't want to enroll patients, have them sign up, consent, assent to surgery, and then all of a sudden not be able to do the surgery because we didn't, or not be able to do the study because we didn't have the medication. So we had to wait for enough volume to be able to have that in our own pharmacy. We also had previous issues with paper pain logs with studies that we've done at the institution, with either families completing them but not bringing them in at the time of follow-up, or not completing them. So we tried to transition to an online system. So we have a Chat with Children's program, which was developed by the anesthesia department, which allows HIPAA compliant text messaging to be able to log pain and medication use post-operatively. That took a little bit of a process working with the IRB and then working with the anesthesia department to be able to get virtual pain logs. We also then had to, again, try and standardize as much as we could. So we worked with our spine anesthesia colleagues to come up with a spinal anesthetic protocol to try and standardize the amount of narcotics intraoperatively, as well as the use of other pain medications, either things like Precedex or Ketorolac, to make sure that we keep things as uniform as possible. And then again, working with our investigational drug pharmacy, who initially likes to verify consent and assent independently to ensure that there's no issue there. And so they wanted 48 hours of lead time, which isn't always when we have our preoperative visits. So a couple of struggles in the beginning, but we're now nearly to halfway. Our power analysis showed that we needed 52 patients. We have 23 that have been enrolled, 19 have completed the entirety of their course. And so we actually do have a decent percentage of patients that are willing to enroll of those approached. Normally for an RCT, it's closer to in the 30s, but we've been able to get numbers closer to the mid 60s. So if we look at our preliminary results of the patients that are included, we can see that it really does reflect the AIS population with a preponderance of females more than males with an average age of 15. Just of note, 4 out of the 19 that have completed all of their surveys did have some pre-operative back pain. And then if we look at the surgical preliminary results, we can see, again, average age is consistent with AIS, preoperative Cobb angle into the mid 50s with kind of appropriate and expected blood loss surgical time. And then importantly, no complications. We're still awaiting kind of the unblinded data, which we don't have right now, but hopefully we'll have updated information. Our goals are to have kind of completed enrollment by the summer or the scoliosis season of 2023. And then possible continuation. We have approval up to 100 patients if things are going smoothly, and then further analysis. I'm sure one of the questions that will come up is the possibility of liposomal bupivacaine, and so we can get into that a little bit during the discussion. We chose the bupivacaine with epinephrine, but I do think that that's a logical next step, is to look at more kind of updated medications like the liposomal bupivacaine, but happy to talk more about the study. Thanks.
Well, Dr. Birch, thank you very much, and the discussion is open. Please put in your questions there for Dr. Birch. Craig, just as we get started here, tell us a little bit about your current multimodal pain management and what this is sort of falling on the top of.
Yeah, that's a good point, because I know everywhere kind of across the country and across the world do things slightly differently. Our current protocol is that for the first 24 hours postoperatively, patients do have a PCA, which is IV morphine. They also do get ketorolac postoperatively for the first 2 days, and then transition to PO, ibuprofen. And then they also get acetaminophen. And the other medication that we routinely use is diazepam. And so that's our current postoperative regimen that's been standardized with our pain treatment specialists, because the anesthesia department follows those patients until they're fully transitioned over to PO regimen, and then the orthopedic department manages their pain control following that. And then intraoperatively, the narcotic that's used is fentanyl, just for the quicker on and off time period. And then the kind of remainder of that's been standardized to minimize the inhaled anesthetic.
And then are you using steroids or gabapentin in addition to those?
We are not. It's been something that we had discussed doing as a group, but we decided to hold off on changing too much, even though there has been a lot of research recently about the use of steroids, which appears to be promising. And then gabapentin had previously been used, I think it was closer to 5 or 6 years ago, with a preoperative dose and a postoperative regimen. But we had gotten away from that because there was not a difference that was noted kind of anecdotally within our group. And so in an effort to standardize and not change too many things at once, we have not adopted the steroids yet, but we'd revisit once this kind of study's completed.
Michelle Marks has a question. Dr. Burks, congrats on over 60% enrollment in RCT. Do you have some pearls to share for future investigators, tactics used on consenting and enrolling patients?
Yeah, I think it is one of those things that does take time. And I think one of the reasons that there's certainly kind of from the patient side of things, the fear of randomization if they get attached to one limb. And so I think some of the people that we have had who have determined not to consent or assent to the randomization is that they then want the medication arm. And so I think having a discussion, I also think having the surgeon that has a longer standing relationship with the patient, having us intimately involved, I think does help because they feel more comfortable asking questions with us as opposed to someone that they just met with a research team. I think that's been very helpful as well. But I think the biggest thing is time. So as opposed to a really quick introduction that says, oh, we're doing this study, we're trying to see if we can help with pain afterwards. Are you willing to be randomized? It's kind of a little bit of a longer discussion. So it typically takes 10 to 15 minutes to go through everything, which is a hefty amount of time, but it has been helpful.
Dr. Kwan has a question. Can you explain how bias can be avoided systematically in a study such as yours?
I think that's a really big question. I think some of it would be kind of specifically what type of bias you'd be alluding to. I think the goal was to really standardize things as much as possible. So we're trying to get, it's a relatively small group of people that actually meet all of the criteria because we try to come up with very strict inclusion and exclusion criteria. Pain is a really hard thing to study because you have obviously the painful stimulus, but then kind of it's much harder to control the response to that and how people experience that. And so we tried to be as thorough as possible at controlling to have such similar groups, which would hopefully kind of reduce the bias. The other part too is that there's a little bit of built-in bias because it's a single institution. And so it's just localized to predominantly the New England area and the population within the New England area. And so I think that's a harder thing to do, but obviously making that a broader study in the future and having other people replicate it in their own institution would be really helpful.
Last question, and you sort of touched on it a little bit more, was but Dr. Hayashi. Pain perception is truly, for the most part, is subjective. Have you thought about running some sort of psychological clearance for the study?
We have not. We talked about it briefly, and I think that's kind of something that probably gets talked about with all pain studies, is because obviously you try to control the stimulus, but it's very hard to control the response. And there is a lot of variability, both in the interpretation of the painful stimulus, as well as the response to it, as well as the response to the medication. There's a lot of variability there. So it was something that we kind of mentioned and discussed. And that was one of the exclusion criteria, being kind of an underlying mental health diagnosis, which can correlate to being a little bit less consistent of a reaction. And so we did what we could. I think that's a very valid point to talk about psychological screening before. And I think that'd be valuable information for the future, for sure, to predict who's going to kind of sail through it smoothly, who's going to have more difficulty. I think that's a good point.
Dr. Birch, I want to thank you. It was a great presentation, and we're going to move on to our next by Dr. Nike Henepe, SmartVest as a measurement instrument for pulmonary function and adolescent idiopathic scoliosis, an exploratory study. Niki.
Well, thank you very much for the opportunity to present here. Let me just share my screen. I pre-recorded it to make sure I made it within the 6 minutes. So.
Hello, my name is Nick Venepe. I'm an orthopedic resident in Radboud UMC in Nijmegen, the Netherlands, and I would like to present our ongoing study of using smart shirts for continuous measurement of pulmonary function in adolescent idiopathic scoliosis. So as a disclosure, this research was funded by the SRS research microcom, so special thanks to the SRS, and I have no further disclosures to mention. The pulmonary function can be impaired in scoliosis due to thoracic case deformity and the reduced chest wall compliance, and this can lead to a decreased lung volumes. And shown here on the right bottom, a bronchial airway obstruction can be seen, shown by a 3D CT scanner, and this can lead to increased airway resistance. So this decrease in pulmonary volumes to the FVC, the forced vital capacity, and the FEV1, the forced expiratory volume in 1 second, has been correlated with the Cobb angle, and a recent systematic review by Kempen et al. Showed a linear decline in pulmonary volumes with the increase in Cobb. And this is applicable for the full range of Cobb angles, so not only the large curves. So this pulmonary function or symptoms has been recognized as an important outcome measure by both clinicians and patients. And in a recent exploratory survey, almost half of the patients experienced pulmonary symptoms, and a significant amount of them, their daily activities were limited by these symptoms, and they worsened with an increased fatigue or tiredness. So no standardized method exists currently to measure this pulmonary function. It is often performed by spirometry. The limitation is that it's single-timed and it's a forced measurement, and it is performed while resting. So in COPD patients, a smart shirt has been investigated to measure tidal volume during activities. And the shirt is shown here on the right. It is a company called Hexaskin, and it is a shirt that has heart sensors, respiratory sensors, and activity sensors. And we wondered if it is also feasible in AS patients. So these are study objectives, primarily to explore the feasibility of using a smart shirt and to describe the changes in tidal volumes during walking, and to explore the relationship between these pulmonary volumes and the level of experienced breathlessness. And we measure that is measured by the modified form of this NIA scale. It ranges from 0 to 10, where 10 is the maximal amount of experienced breathlessness. So we're including AS patients ranging from 60 to 35 years old with a thoracic curve of at least 30 degrees, and exclusion criteria are spinal surgery, pulmonary diseases, and smoking. So we'll perform a baseline spirometry at the beginning to describe their pulmonary status, and we'll walk a standardized trail of 30 minutes, including climbing the stairs. And this pulmonary volumes are measured by this smart shirt, and their breathlessness with the dyspnea scale of modified ball. So the preliminary results of our first patient, it is a female of 20 years old with a thoracic curve angle of approximately 45 degrees, and the spirometry is within normal range, shown here on the bottom. In the red, the percentage of her predicted values, so that is 90 to 100%, so that is normal. And these are the kind of results that we receive from the shirts, and I'll zoom in on this. So her heart rate shown here over time, you see that it increases over time until the point where we start walking the stairs. And at this moment, the heart rate increases until 150 almost, and we climb 3 flights of stairs, so you see 3 peaks. And the amount of breathlessness at the beginning was 3 out of 10. After 10 minutes, it's 7 out of 10, so quite severe. And after 20 minutes, 5 out of 10. And after climbing the stairs, she experienced a breathlessness of 8 out of 10, so a very severe amount of breathlessness. So her breathing rate is shown here over time. You see a slight increase during time, but it stayed more or less the same, and no big increase after walking the stairs. And the minute ventilation, so the amount of breath, amount of air exhaled and inhaled in 1 minute, is shown here. And you see an increase after walking the stairs, but no big increase during overall. And her tidal volumes, at the beginning they increase, but over time they decrease, even though she experienced that amount of breathlessness. So as a conclusion, it is an ongoing feasibility study, and the interpretation of her first results is subjectively, despite her normal spirometry, she experienced severe breathlessness during walking. And objectively, it is too early to say if the shirt can really quantify the pulmonary effort. So what's next is further patient inclusion and descriptive analysis. And for a future perspective, we'll need a larger population if it seems feasible in AS patients. And we'll need a case control study with a comparison of healthy subjects. And we need to elucidate the problem of breathlessness and exercise intolerance in patients with a deformity in the spine and the trunk. So we propose a lunchtime symposium regarding pulmonary function in spinal deformity during the SRS annual meeting. So these are the references, and I would like to thank you for your attention. Are there any questions?
Again, please type in your questions into the question and answer portion of this. Dr. Hennepy, this is a very interesting study looking at something that's been a challenge for all of us, because trying to get the pulmonary function tests, trying to correlate with them with what is occurring, and identifying how those actually relate to activities of daily living and what's happening when people are doing normal activities or exercising has been very challenging overall. It's a technical question on this. How is it actually measuring the inspiratory and expiratory flow? Is this by volumetric changes? What's happening with that?
So it has two circumferential bands around the thorax and the abdomen. So it measures the amount of the circumference with an inspiration and expiration, and that combined with the breathing rate, that gives us the minute ventilation. So it's a big estimate actually on how much air is inhaled and exhaled. It is not compared to the spirometer itself.
How well has this been validated in the COPD population?
Well, in the COPD population, it has been validated, and it has been tested if the amount of air that the vest or the shirt generates is equal to the amount of air that a spirometer measures. And that was quite similar, that was quite good, but yeah, in a scoliosis patient's population, it has not yet been tested. So
how small can they make these? Can this be something that's adapted for early onset scoliosis, or are there problems with the shirt itself as it tries to fit a deformed thorax? What are some of the limitations that you see with it?
Well, I think the biggest limitation is that they have their own algorithm on measuring and calculating the amount of air, but that has all been performed and done in a healthy population. So I think that's the biggest issue momentarily, that we do not really know how many milliliters or liters are inhaled and exhaled, but I think we can really what we really can do is to see what are the changes when in percentages, not necessarily the amount of amount of air, but the percentage of change. I think that's quite solid.
Are they flexible enough that they can fit a deformed thorax well?
Yes, they can. It's really stretchy fabric, and they have their sizes ranges from an extra small to an extra large. So they can fit almost any human on planet Earth.
Mm-hmm. So a question from Daraya Tesakava. What do you think about primary lung disorders in patients with idiopathic scoliosis? Do you think it could reflect your study results?
The pulmonary, that's why we exclude them. We do not want to include any patient that has an alternative reason why their pulmonary volumes can be declined. Pulmonary, the use of pulmonary medication is also exclusion criteria. Smoking and any other pulmonary diseases, we exclude them for this reason.
And how many subjects have you enrolled so far?
So far, one. Yes, and two. And in the next 2 weeks, the next two patients will be included. And we aim to measure 6 patients first for this feasibility study, because we just want to see if it is usable in this population. So we want 6 patients in total.
So I have a question. I'm so curious about this shirt, following on to the earlier question. I'm wondering, is it how how lightweight is it? How expensive is it? Are patients receptive to it? And is this something that you would foresee a patient wearing under a brace, for example?
Well, thank you. That's a good question. Well, it's very lightweight. The fabric is the patient who worn it, and I've worn it myself quite a few times. When you're actually busy walking or you're doing activities, you almost don't notice wearing it. But it is an extra layer of clothing, so it's a little bit more warm than normally. But it is lightweight and very thin fabric. Yeah.
The warmth may not be an issue where you are. It may be an issue in Dallas with Dr. Wise over there.
Yeah.
A question from Dr. Pasius. Is this thought to reflect real-time data or cumulative changes over a period of time?
Well, it is real-time data. You get you can download from their own online database the raw data. So and it refreshes every second, I think. So it's real-time data. Yeah.
Do you foresee this being used in conjunction with the brace monitor? And how does it deal with the expansion within the brace? Would we see changes simply because a patient is wearing a brace?
Well, I wonder if the measurements that you receive from the shirt will be accurate when extra force is applied from the outside. So I think it's difficult, that we need to test it if it's possible, because the fabric needs to stretch out and have no limitations on pressure from the outside. So I'm not quite sure if it's really possible. We have to test it, I think.
Well, I want to thank the last three presenters. These were great talks. We now have about 10 minutes where we will be viewing a video which has been produced by the SRS Safety Committee in the development of a safety checklist. And with that,
hi, I'm Doug Burton. I'm the Research Council Chair for the Scoliosis Research Society, and I'm here with Feroz Mianji, who is the current Safety and Value Chair, right?
Correct. Yep. I'm excited that this year I'm going to be chairing that committee.
Yeah. And with us is Lloyd Hay. And Lloyd, tell us a little bit about why you're here. What's your role?
Well, I was Safety and Value Chair several years ago, but over the last 6 years, I've been working on an ongoing project to develop an SRS checklist for spine safety.
Yeah, and it's been an ongoing process. Lloyd, tell us a little bit about the steps, the process that you and the team have gone through to get us to this point.
That's a great question. So 6 years ago, actually, at one of our annual meetings, Steve Andre gave a really passionate speech about how we all have to do something because healthcare is really going down the tubes. And that really just rang in my ears that night. So the next day I talked to a couple of SRS colleagues at a breakfast. And I had this idea about applying aviation-type checklists to healthcare because I've been using them as a pilot. And so I talked to Jim Sanders, Dan Sakato, and said, that's a great idea. So that validation of the idea. So we started to pull forward with that. And over the last 6 years, we developed a platform for that, but then actually developed the content. And actually just recently, we now have an approved SRS checklist for helping get the patient through surgery on the day of surgery.
Feroz, tell me about this checklist. I mean, what all is in it? What's it make up?
Oh, excellent. I mean, I think credit to Lloyd and the membership for pushing this through. So, as Lloyd said, it's really the patient's journey through the OR. So it starts when the patient comes into the room, how you position them. You want to go through a checklist, what you're going to do to optimize them just before you make a skin incision, what you're doing during that procedure, and of course, what you're going to do following that procedure. So it's really an intraoperative checklist. You can customize it to your team or to your center as well. So I think it's been a really great push from Lloyd's leadership of the SRS QSVI committee to make this checklist, have it available in an effort to try and push safety in many of the centers globally.
So, Lloyd, who do you see as being the groups that would benefit from using this?
I think the key thing is this is really meant to be used by all SRS surgeons, whether you're pediatric or adult. And I do both. And I've actually done over 1,000 surgeries now, kids and adults with this surgery. So really any SRS surgeon and their team can benefit from the surgery. And that's a big part of this, is it's not just the surgeon, but using the checklist to get the whole OR team to work together. I have to tell you, when I first started the checklist in the OR, I was really scared that how is my team going to respond to this? Is the OR nurse going to yell at me? But it's amazing how they warmly received it. In fact, the first OR nurse, when I rolled this out, when I had the checklist up on the screen, she said it was the music for the orchestra. It actually helped pull the whole OR along. So if you're fearful about trying it, I can tell you your OR staff will actually embrace it. And it's been really, really helpful for onboarding new staff, which is always an issue for us now in this post-COVID world because there's so much staff turnover.
Yeah. If I'm not an SRS member, can I use this?
Absolutely, absolutely. We encourage that. You can actually download it from the website, and there's a URL you can go to and actually download the checklist free of charge, and we encourage everyone to use it. And we really encourage every SRS member to be an influencer at their hospital and to share it with their spine colleagues, because it's useful not just for kids and adults, but it's also useful for not just deformity surgery, but non-deformity surgery as well.
So let's say I practice in a country where English is not the first language, and I want it in another language. How can I get it in another language? Is that version available?
Not yet. We do have one language now, which is in Portuguese, which is the older checklist that we're going to be transitioning over to that. But I think that is something that we should work on as a committee, to work with our international colleagues to get it into each language. But we can provide the text, and it could be translated using Google. But then what we really need SRS members to step up so that every OR team has it in their own language. But I think that's a very good goal.
Feroz, is this a prescriptive formula? I mean, is this something that I need to be following step by step?
No, I think, Doug, again, as I was saying, I mean, it's a good place to start. It's an intended use. It's not something mandatory. It's not something the SRS has said that, this must be in every single OR and you have to do this. It's an intended use. It's just to encourage an environment of safety to all the ORs, and I think it's a really nice first step. So I think for all centers, it's just something that they can use at their leisure. So
right. Well, listen, Feroz, Lloyd, thank you guys so much. Number one, for all the work that you put into this. I know that even though it's one sheet of paper, it was hours and hours of work to get a consensus on that. So thank you for all your work, and thank you for taking the time to explain to us about this SRS checklist that you've created.
Well, excellent. Thank you also, just Doug, and for the SRS leadership to get behind this, because I think that's part of what's really made it be successful. But I think, as Feroz was saying, it's a great starting point, but we really hope this will help each team to develop their own quality, safety, quality improvement cycle that can keep getting things better and better, safer and safer.
Well said. Thank you.
Thank you.
I want to thank everyone for your attention to the video. Please go to the site, figure out how you can incorporate this type of checklist into your practice. I found it very helpful in mine as a non-paid advertisement right here. For the next half of this, I would like to introduce my co-moderator, Dr. Carol Wise at Texas Scottish Rite Hospital, who has been doing outstanding scoliosis research, including SRS funded research, for quite a while, despite being as young as she is. Carol, I'm going to turn it over to you.
Oh, thank you. That's the best introduction I've ever had, I think. Good morning, good afternoon, good evening, everyone. I am honored to be here. I'm honored to be co-moderating with Dr. Sanders. And it is astonishing that this is our third year to lead this symposium. And I think you've already seen in the first half the diversity of research that is supported by SRS, and the quality also. And I have to say, I'm happy to hear people giving sort of their they're honest assessments of the challenges that you face in research projects, because it's universal and it's helpful to your colleagues to hear the steps that you've gone through and the patience with a C that it takes to drive research, solid research. So congratulations to our first speakers. And I am going to take advantage of my position here now to say thank you to Scoliosis Research Society. I can give a little testimonial that SRS gave me my start. The first grant I ever wrote was to the SRS, and it was from this person that nobody had ever heard of down in Dallas, and I wanted to recruit patients to start genetic studies. And I was funded, and that was literally what gave me my start. So I first and foremost appreciate that so much, and hopefully, I just to the researchers who are on the meeting today, I see a very bright future in research for all of you. So we will now turn to the second half of our program. Let me bring up our agenda. So our next speaker is Dr. Kylie Tucker, who will be presenting her research that's funded by a standard SRS grant. And her research, the title of her talk this morning is Novel Insights Toward Non-Invasive Predictors of Adolescent Idiopathic Scoliosis, a comprehensive examination of musculoskeletal asymmetry. Dr. Tucker.
Thanks so much. Thank you to SRS for the invitation to present here today. Now, our team aims to identify new musculoskeletal biomarkers that may help to predict disease progression in adolescent idiopathic scoliosis, and I don't have any additional disclosures to report. So in AIS, the 3D deformation of the spine is really well characterized from the lateral shift, tilt and rotation of the vertebra to vertebral wedging and asymmetrical spinous process formation. And we know that bone shape is affected by the forces that are applied to them. And we know that muscles apply forces to bone. So here we're asking if an asymmetry in the paraspinal muscle forces could contribute to disease progression in AIS. So there are many factors that can contribute to muscle force. For example, we have muscle activation. We can think about the amplitude of muscle activation, how much of that muscle is being activated. We can think about the onset timing of the muscles. Are the muscles being activated at the same time, or is one coming on before the other with the tasks that we're performing? We can think about the muscle size. A larger muscle is likely to be able to produce more force, but if a larger muscle hasn't got good quality, if it's got more fatty infiltration, then maybe it's not able to produce the same amount of force. And also insertion points of these muscles and their line of action, they're really going to affect how and where this force is being applied to the bones. So in this study, we're considering all of these factors and more, and I can share just some preliminary results with you today. So let me show you some data based on just 11 controls and 11 participants with adolescent idiopathic scoliosis to date, remembering that we're only partway through this data collection. So I'm showing you here one of our participants or two of our participants with surface electrodes to record paraspinal muscle activation at 4 different levels of the spine. And this is my own daughter participating in some pilot trials before we started to bring our participants into the lab performing some of the tasks. Now, one of the first questions that we asked in this study is which task is best to elicit maximal activation of paraspinal muscles in adolescents? Now, this is really important because if we want to interpret any data that is collected during submaximal activation tasks, we need to normalize this data to that which is obtained during a maximum voluntary contraction. And the results of this first study were really striking. So this is data just from 11 AIS participants here, from just one of the muscles that we're recording data from. This data here has been recorded during the Superwoman task, and this one during a resisted back extension task. And if I just highlight this one participant here, it shows you that during this Superwoman task, she was able to activate her muscles really well. But in this resisted task, back extension task here, she was only able to activate her back muscles at about 52% of maximum. And then if we look at another participant, we see almost exactly the opposite. So in this participant here, she was able to activate her muscles really well during the resisted task, but not the Superwoman task. Now, if we look across all of the participants that we've seen so far, about half of the participants are able to activate their paraspinal muscles more during one task and half in the other task. And it's different between their muscles. So it's not like half of the people are superwomen and half need the resisted, but actually different muscles need different tasks as well. So this shows us that our kids need to be given the opportunity to perform both of these tasks to determine what their maximal paraspinal muscle activation is if we're going to normalise any of our activation data during motor tasks in such things. And this work has some really important implications for previous work that's been published already in activation of back muscles where maximum voluntary contractions even haven't been done or they haven't been done particularly well. And it also provides some really clear guides as to what we need to do in future muscle activation studies. But let's have a look at a couple of other tasks that we're doing in the lab. So here is one of our participants doing a submaximal Superwoman task here, where we're going to be measuring her muscle activation normalised to maximum voluntary contraction. This one is again my daughter, so I can show you her face on the screen here. She's currently having to respond as quickly as possible when there's a light stimulus given. So this is a version of an internal perturbation. And in this example over on the side here, we've got a load, which is an axial load on the shoulders, which is delivered at a random time on the children when they're sitting on a stool here. So these are internal and external perturbations, and we can have a look at the activation onset latency of the paraspinal muscle. So each of these tasks give us quite a different perspective of how the motor control may be different in kids with scoliosis compared to the typically developing cohort. So just a little bit of data that we've been able to analyse so far. So this data is from the submaximal Superwoman task, which you can see being performed here. And what you can see, I hope straight away, is that at the level of the 12th thoracic vertebra, we see a significant asymmetry in the muscle activation with about 1.5 times more activation on the convex side of the spine compared to the concave side of the spine. And you might also see here as well, and I expect with a few more participants, we'll also identify this asymmetry occurring at the level of the T9 vertebra. Next, I can show you some images from the MRIs that we're taking. So we're now able to segment out with far greater precision ever before a larger number of paraspinal muscles in our children. And once we've used these MRIs, we can calculate the volume of muscles at different vertebral levels or throughout multiple vertebral levels. And just for some very preliminary data here again, I can show you that from the muscles that we're able to segment out here now, the only place where we're identifying a difference in volume so far is in the multifidus muscle at the level of the apex, with a greater volume on the right or the concave side of the spine of our participants. But I said to you, it's not just about volume, it's also about the quality of the muscle. And this data hasn't been analysed yet, but I can show, but I've seen this now on a number of the images that we've seen. So I expect that this is what we're going to see as we go forward. So here's some fatty infiltration data. So the white shows fat and the dark is muscle. And you can see, I hope, really clearly here to start off with, that in the multifidus region here on the concave side of the child with AIS, we have a lot more fatty infiltration. So while we've got a bigger volume, we haven't necessarily got good contractile muscle within that region. So this is the first time that each of these measures and more that I've not described here today are being collected in the same cohort of kids with adolescent idiopathic scoliosis. And it's important that they're being collected together in the same cohort, because this is the only way that we're going to be able to begin to understand how these factors interrelate, and they're all important in force generating capacity. So I'd like to just finish off by mentioning the wonderful team that includes biomedical scientists, physiotherapists, an engineer and an orthopaedic surgeon who've come together to do this project. And I really look forward to sharing more exciting outcomes with you over the next little while. Thank you.
Thank you, Dr. Tucker, for a fascinating presentation. I have several questions while we're waiting for other questions to populate. So I was thinking, coming from a genetics point of view, many years ago, the strongest link that was identified to AIS genetically, and I say strongest meaning just the greatest odds ratio, this was first identified by Shiro Ikegawa in Japan, is a gene called, is a signal just beside a gene called LBX1. And LBX1 is very important in determining muscle early in development. And it controls a lot of other genes that are important in patterning and developing muscle. And so as you were speaking, I was wondering about the old question of, first of all, of cause and effect. You described seeing differences in muscles on either side, and I'd like to hear your thoughts on that. The other question in my mind is there an initial patterning difference? In other words, could the cellular content of the muscles be different on either side, for example? And perhaps you have a different reservoir of muscle stem cells in patients with AIS that could explain the differences that you're seeing, or could partially explain the differences that you're seeing. It's one hypothesis. So I'd love to hear your thoughts on both of those things.
Brilliant, thank you. So the first part of that question relates to the chicken and the egg, and it is the question that will always come up with these kind of talks. So one of the ways to, so I don't believe that the way that the study is currently designed can answer that question, right? But I think that we're providing the tools that if we then use these, if we demonstrate the feasibility of using these tools over a longitudinal sense, with a cohort, then we can start to also use these in other cohorts where perhaps we know which is the chicken and which is the egg, right? So there are some cohorts, and you will all know far more about this than me. I'm a biomedical scientist, so I bring in the biomedical science, not the clinical skills, into this research team. But you'll know that there are populations of people, children, who after an insult, like a neurological insult, let's say CP, SCOLI, so more of a neuromuscular scoliosis, where we know what the origin is. We know that it's a neural insult to begin with, and that there are therefore changes downstream in the muscles and then in the bone that will occur over time. So I think that if we can use these skills to look longitudinally in both our AIS cohort, but then perhaps also in a cohort like a neuromuscular cohort, or perhaps even a cohort of kids that develop scoliosis following a cancer diagnosis and treatment, or things like that, we might be able to start to interrogate more along the lines of the chicken and the egg. The other part of your question was about the quality, I guess, of the muscle, so the stem cells in the muscle, so very early on in development, and how they may affect the ongoing development. And so I think it's a really important question to ask. I would be interested to understand more about whether a change in a gene can affect a very particular part of the musculoskeletal system. So I'm not aware of that, but it's not my area of expertise. But why a particular gene would result in a change in fatty infiltration, muscle volume at just one particular location isn't quite so clear to me, but perhaps it's just one part of many factors that come together that mean that these real changes that we're seeing in the muscle are only occurring in really kind of isolated parts of the spine. So it's about putting together lots of different pieces of the puzzle, I think, and that must be certainly one of them.
Thank you. We could have more discussion on that. But we have quite a few other questions. Dr. Tesakova says, thank you. Do you use routine electromyography for your IS patients? And if so, does it correlate with your Superwoman test and MRI findings?
Yeah, beautiful. So at the moment, the data that we're presenting here is just using a standard surface EMG setup. So within our lab, we can also perform intramuscular EMG and high density surface EMG, but this data is all from just standard bipolar electrical EMG recordings. One of the things that I'm really passionate about, though, is ensuring that we have as many people around the world doing really great motor control studies in these populations and other populations. And I would, if people are interested in using EMG, well, I'd really refer folks to some consensus statements that have been formed recently in the EMG field. They're called the SEED project, CEDE, and they provide some really lovely guidelines for folks about what's important to think about when using EMG to record muscle activity. Because I think there's quite a lot of people that are working in this field around the world. And I think if we can all make sure that we're collecting really robust data and also reporting them well and reporting data based on individuals as well as group data, I think we can get a lot more meta-analysis being done. So that was an EMG part of the question. Sorry, I got off track. What was the second part of that question?
The question is no longer in front of me.
So in relation to the MRI parts of the study, so I think it's really fascinating as well, because the changes that we're seeing with MRI are the deep muscles, not the superficial muscles. But of course, when we're using surface EMG to record muscle activation, it's going to be very much biased to the more superficial muscles. So what we're identifying is a greater activation or an asymmetry in activation in superficial muscles to perform these tasks. And quite separate to that, we're also identifying these changes in morphology and quality of the deep paraspinal muscles. So I can't say that they are, so they're looking at the system in a slightly different way at the moment. That it's not, we're not recording from the same muscles with EMG as what we have, where we've identified the changes with MRI. And that's a limitation to the technology at this stage.
Thank you for outstanding presentation. We had quite a few other questions that we would ask you to address because we're going to move on to our next presentation. Thank you again. Our next speaker is Dr. Jacob Greenberg, who will be presenting a talk using ecological momentary assessment and digital phenotyping to create personalized disease profiles for adult spinal deformity. Dr. Greenberg.
Hi, thanks so much. But yeah, thank you for the opportunity to be here. I'm going to be talking about our study using mobile health technology to hopefully in the long term improve care of adult spinal deformity. Currently on the spine field is the Cleveland Clinic, and talking about work that's been largely done at Washington University, but certainly with appreciation from support of the Cleveland Clinic. No disclosures. So in terms of some brief background, I think many people here probably realize that predicting outcomes from adult spinal deformity surgery remains quite challenging despite using large, high quality, and even prospectively gathered data sets. And along the same lines, we know that things like patient functional status and psychosocial health are important influences on outcome, but we don't always or maybe often do a good job of effectively capturing and quantifying the most important aspects of these measures. And our hypothesis is that mobile health technology could capture individual differences that we don't see with our traditional patient-reported outcomes that could help us inform our surgical decision-making. So we developed a mobile health assessment protocol where preoperatively patients completed brief mobile surveys several times during the day on their smartphones called ecological momentary assessments, or EMAs. These are brief mobile surveys where patients are sent a prompt and asked to rate, say, their pain severity, mood, disability, and catastrophizing. At the same time, we passively monitor their function using Fitbit wearable devices. In the post-operative setting, we continued the Fitbit device while we sent them brief mobile surveys, but less frequently, just once in the evening. At the same time, we collected a number of more traditional patient-reported outcome measures or PROMs in both the preoperative and postoperative setting, gauging measures that are probably familiar to many people, like PROMIS measures of pain interference, ODI, SRS-22, as well as a variety of mental health measures. And so it's going to move on and provide a highlight of our results. I'm trying to give an overview of our findings in both our general cohort of lumbar and thoracolumbar fusion patients and how some of that relates specifically to some of our findings in our deformity patients. So thus far, we've recruited and enrolled about 120 patients who've undergone either a lumbar or thoracolumbar fusion. And of those, about 25 have specifically been ASD patients who have undergone a thoracolumbar fusion for deformity. Overall, these cohorts have fairly similar demographics, albeit a little bit older in our deformity patients. And moving on to some of our preliminary results, we found that overall this assessment was very feasible in terms of patients' ability to complete it. In the preoperative setting, participants completed an average of almost 60 of these brief mobile surveys or EMAs and had almost 16 days with at least 8 hours of Fitbit data wear time, giving us quite a large volume of data to be able to analyze. Next, just started to look at some of the results from these assessments in terms of the momentary pain and other symptom domains we've captured. So you can see here basically the distribution of average scores across each different symptom domain. You can see there's a pretty wide range of disease severity across the population, and that's true both in our overall lumbar thoracolumbar fusion cohort and also in our deformity patients. You can see that the distribution and average symptom severity does seem fairly similar in both groups. Next, we've tried to take things a step further and actually start to look at some of and take advantage of some of the longitudinal information that we gain from these EMAs, which is fundamentally different from our traditional patient-reported outcome measures. So in some work led by Maddie Frumkin, a psychology grad student in Tom Rodabau's lab, we've started looking at some of the momentary associations across these different domains. So for example, for an individual, how does your pain severity relate to your depression scores over time? So what is that within-person correlation? So you can see here, both in our overall population, deformity patients specifically, there's a pretty wide range of how strongly these different symptom domains relate to each other within each individual. And that these distributions in terms of the types of relationships we see are pretty similar in both our overall population, deformity patients specifically. Similarly, we've tried to derive a variety of clinically important measures from the Fitbit data. This work's been really led with a lot of effort from Jingwei Zhang, who's a graduate student training Lu's lab, also at WashU. So for example, and these are just a small selection of some of the variables we've developed. We've developed variables or derived variables related to just overall activity, say step counts, which we get directly from Fitbit, and then we normalize based on wear time. Also activity intensity, such as the maximum number of steps, say within a 6-minute or 30-minute window. And again, you can see there's a pretty wide range of those measures in both cohorts, and that the overall numbers or types of activity levels seem similar in both cohorts, but that activity levels were a little bit lower in the deformity patients, which probably is not too surprising. So next, we've been working on some predictive analyses. Just because of where we're at with the study, we've been focusing on some early postoperative outcomes, particularly 1 month after surgery. So for example, we've been looking at PROMIS pain interference scores 1 month after surgery. And what we found is when we tried to use traditional patient-reported outcomes, things like ODI, PROMIS scores, SRS, that basically predictions were quite poor. So discrimination or C statistic was 0.59, which means we were basically predicting only slightly better than chance. But when we brought in our data from EMA and from Fitbit, that we're actually able to achieve quite a good discrimination with a C statistic of almost 0.8. When we look at the most influential variables from those models, we can see that it's almost entirely the EMA and Fitbit variables driving that work, whether that be related to things like pain variability or the momentary associations between pain and mood scores. And again, just a credit to Ziki Shoes, another grad student training Lu's lab, who's really put in a lot of effort with some of this predictive work. We've done some similar analyses with the looking at quality of recovery scale 1 month after surgery. And here you can see that when we use our traditional PROMs, that they actually do a pretty poor job predicting worse than chance alone would expect with a C statistic of 0.33. But when we bring in the EMA and particularly Fitbit data, that we do substantially better. So our C statistic is 0.72, which is not incredible, but is reasonable or moderate discrimination, and certainly dramatically better than we're able to do with our traditional proms. And again, not surprisingly, it's really entirely the EMA and Fitbit variables that are the most influential model predictors that are driving that result. And then lastly, highlight some of the most recent work we've done with, again, a credit to Maddie Frumkin, Jingwen Zhang, trying to really relate our EMA and Fitbit variables to each other within people over time. So what do I mean by that? Well, for example, within an individual, how strongly is, say, your activity level in 1 hour related to how you answer your EMA pain scores in, say, the hour after that? How strongly is your activity level actually tied to your pain in ways that we can objectively quantify? And so you can see here is there's basically a range in how strongly those things are correlated within people. And then we've looked at those relationships and see how that seems to impact your short-term outcome. So kind of a little bit, kind of have to follow me with these graphs. But basically, for example, on the left, what we can see is that people who have a stronger correlation between their activity level and pain, so when they're more active, they have more pain, those people seem to do better 1 month after surgery. They have a more favorable change in their PROMIS pain interference scores, which is, I think, in line with what we would expect clinically. We see a similar relationship between people who have a stronger association between, say, their heart rate and pain also having a more favorable response early after surgery. And these are the results in our overall, 120 person or some subset thereof population. And we can see similar results in our deformity population, similar trends, and an overall similar significance level, just obviously with fewer people at this point. So at this point, we are trying to work on expanding some of the analyses I've showed, focus on studying postoperative outcomes using that in a variety of ways with the EMA and Fitbit. As we follow these patients longer, we're trying to see if we can gain insights into really how they're doing in the longer term, so at least 1 year out from surgery, to gauge not just recovery, but really the ultimate, kind of longer term benefit from surgery, and then ultimately to use these information to really support more personalized decision making. So I just want to thank our whole team, really, that made this possible. It's really quite a number of people. Our coordinator, Joan, postdoc medical students, Saad, Justin, Kathleen, and Braden, the graduate students I mentioned, Maddie, Ziki, and Jingwen, Mike Kelly has been my main deformity mentor, along with Manish Gupta and Brian Newman, and the rest of our team from WashU, with Zach Ray, Jay Piccirillo, Chenying Liu, Tom Rodaba, and really, even many others. So thank you all very much for the opportunity to be here and present, and for the funding. Thank you to the SRS, and I'd be happy to take any questions.
Thank you, Dr. Greenberg, for an excellent presentation. Fascinating to me, the concept of shifting toward taking data in real time from patients, as opposed to this in sort of more static questionnaires that you referred to. So I can start with one question. We heard a presentation earlier from Dr. Birch, where I think he had switched to using text messaging to obtain some information, sort of somewhat along the same lines as the trend that you're describing. But of course, this raises some issues of privacy. And I think particularly with the Fitbit approach that you used, I'm curious how this was handled, what in terms of what data you were allowed to access and not allowed to access, and how that was controlled. For example, I don't think you would want to know all the information that a Fitbit could give you about your patients. And so how was privacy addressed in your study?
That's a great question. So the data that we specifically gathered from the Fitbits were primarily heart rate, activity, and sleep data. More recently, Fitbit has expanded that somewhat in terms of things like heart rate variability and oxygenation for more of their devices, although I think there's still some ongoing questions related to the reliability of some of those measures. We were very open with patients about what types of data we were collecting for them, why we were, getting these devices. And then we tried to do everything we could to basically protect their privacy. And so in particular, patients didn't log into their Fitbit devices with individual email accounts. We basically created study email accounts that were not identifiable. We were then able to retrieve their Fitbit data from the cloud, and then separately we're kind of able to link that back with their identity using basically a key that we have on secured university servers, so that it's not nothing about their individual identification is available on Fitbit. We kind of have that separation. I think there are other groups that have taken other approaches, including sometimes gathering GPS data, and I think there are, I think, a variety of ways to do this, but ultimately, I think you're right that as we think about using a variety of mobile health technologies to gather more information about people, that thinking about the privacy controls that involves is extremely important, particularly as we think about integrating this with the EHR and other sort of long-term avenues.
Another question, can you explain to me your C statistic? I'm gathering it's a correlation statistic, but I'm sorry, I don't know what that is. How does that compare with an R-squared value, for example? And then part B of my question is, how do you explain that your C statistic was better with your method of data collection than traditional data collection methods?
Yeah, so it's a great question, and it's something I probably should have explained better and kind of glossed over for the interest of time. So the C statistic that we used here is a measure of discrimination for a binary prediction task. So if you're trying to basically predict yes, no, improved, or disease or not disease, or whatever the case may be, how well can we discriminate between people who have the outcome we're trying to predict here, an improvement in promise, say pain interference, or a good outcome based on QOR, versus people who do not have that outcome. And so basically it ranges in the scale from 0 to 1, like a correlation coefficient, but essentially a value of 0.5 would say that you're predicting no better than chance. And a value of 1 would say that you are perfectly able to discriminate who basically, does or does not have your outcome of interest. It's not the only measure, to obviously evaluate a prediction model, but I think it's probably the single most commonly used measure. So it's helpful in just trying to gauge an overall sense of how your model's performing, at least in distinguishing people who, again, do and don't achieve the outcome. In terms of why we think these variables help, I think there's a couple of reasons. I think one is that probably when you ask people to rate some of their symptoms in real time or their momentary ratings, I think that we gather, we avoid some of the problems with, say, recall bias and some of the biases that those things introduce. That our traditional prompts introduce. It's not perfect, but we've done some analysis and show that even with, say, 5 or 6 brief surveys per person, you can get a pretty reliable estimate of, say, what their average symptom severity is, and that symptom severity is often not the same as what we see with our traditional prompts. They're related, fairly strongly, but they're very much not the same, and there's probably, only about a 50% correlation between those two things. I think we're also able to gather other aspects, particularly with some of the correlation data. So for example, I think the more strongly your pain is related to your mood score is probably not a great thing. That may not be true for majority of patients in terms of how strongly those things are related, but that may be a particularly strong risk factor for a subset of patients that we just can't capture with our traditional prompts because we only get a one-time assessment. So I think it's a combination of maybe a more reliable method and ability to look at other things like those correlations or variability over time that we just can't gather with, kind of the traditional methods.
Thank you. It's a fascinating presentation.
Thank you.
We'll move on to our remaining talk this morning. This is from Dr. Baldwin, and he's going to describe results from his project predicting progression of adolescent idiopathic scoliosis using clinical means available widely at point of service, a multi-center prospective study. Dr. Baldwin?
Okay, thanks for the introduction. I'm trying to show my slides. So this is our project predicting progression of adolescent idiopathic scoliosis using clinical means available at point of service. And thanks to the SRS for providing funding for this, we were able to form a sort of coalition of different university settings in order to achieve this this study. I'd like to thank my co-investigators, Ying Li from Michigan, Megan Johnson from Texas Scottish Rite, Grant Hogue from Boston Children's, and Jason Anari from my home institution of CHOP. We have no relevant financial disclosures other than the study funding. I'd also like to thank my my research coordinator, Jenny Zhang, who was instrumental in this project. Predicting curve progression in idiopathic scoliosis is sort of vital to what we do as pediatric orthopedists and pediatric spine surgeons, just in terms of selecting the appropriate treatment, and also to know when growth modulation, physiotherapy, scoliosis-specific exercises, and growth modulation surgeries may or may not be appropriate based on our prediction of the progression. So we did this study in a sort of retrospective fashion. I would say the study was inspired by work by Dr. Sanders and Dr. Shah. There was a figure in Dr. Sanders' JBJS paper relating to the hand X-rays and skeletal maturity, which was sort of mimicked by this this figure that I have here. Which sort of showed like the more skeletally mature and the larger the curve, the more likely the patient was to progress to surgery. So in this paper, we wanted to do that with sort of a larger sample size to kind of get a better idea of what the confidence interval was in terms of curve progression and create like a a stoplight method of figuring out when patients were at high risk of needing surgery. And to my great surprise, like just using the Sanders bone age and the curve size at the time of presentation, we was associated with the area under the curve of 0.088, 0.88, excuse me, which is a very good area under the curve for predicting ones and zeros, basically. However, we had some limitations in that the study was retrospective. A lot of times the bone age was not assessed at the point of service, and natural history was modified by prior preoperative care, non-operative care the patient might have had. The quality of the hand films were not always the best, although our inter-rater reliability was pretty good, and the effects of bracing compliance was not described. So basically, because of this, we wanted to do a more of a prospective study with hopefully a higher sample size eventually to identify distinct high, medium, and low risk cohorts for curve progression to 50 degrees using curve size and Sanders stage presentation. And within each strata, we wanted to identify brace wear recommendations to reduce risk of curve progression into surgical range based on pre-treatment risk, but also to sort of minimize the psychosocial effects of bracing and minimize the amount of time braces needed to be worn. And basically to come up with almost like a Framingham study version of, for idiopathic scoliosis. So in terms of methods, we prospectively studied 4 sites. Our pilot study goal, which is the funding for this study, was 500 patients. Inclusion criteria are new patients identified with adolescent idiopathic scoliosis between 10 and 16 years old, with a major Cobb angle between 10 and 45 degrees, with a Sanders bone age of 8 or less at new patient visit. Data collection, we collect demographics, history and physical exam, radiographic exam, and objective bracing compliance through a heat sensor or button. And finalization is what a success is defined as major Cobb at less than 50 at Sanders 7 with radius of 10 or ulna 9, and fail is greater than major Cobb with greater than 50 degrees. I put an asterisk under success because if patients were between 45 and 50 degrees, then we would have to follow them for 2 years to make sure that they didn't have any further progression. So far what we have, this is preliminary data. For anybody that set up a prospective trial before, there's a lot of data use agreements and IRB related things that have to happen first. So we started this study about a year and 3 months ago. So we needed to set each data use agreement up at each site, and IRBs had to be cleared at each site. So far at the initial visit, we had 69% female, median age of 12.9 years. Median COB of newly presenting patients was 24 degrees with a median Sanders of 4, with a spread of the Sanders classification down here. Total enroll we have so far is 166 patients. Our bracing cohort has 63. Our observation cohort has 102. We have follow-up of 6 months plus on around 148 patients and 12 months plus at around 110 patients. We have only 4 patients so far that have graduated with 2 successes and 2 failures. We average of 18 hours of prescription brace wear, with minimum of 12 hours and maximum of 23 hours. These are observational, so it's based on the provider. Heat sensor compliance data shows that median brace wear is around 17 hours with a minimum of 9.4 and a maximum of 20. So our pilot study goal is 500 patients to generate the initial stratified risk table. Hopefully we'll be done with that. I said 2024, it's probably going to end up being more like 2025 just based on the lag time. Data collection, and hopefully we'll achieve more funding and add more sites. And as I said, because there's so many more variables that we like to initially look at, curve apex, curve location, and other variables, that I think we would probably need a much larger amount of patients to adequately power each risk table cell, and also to identify other risk factors, similar to the way the Framingham study went on for many, many years, and added risk factors as they went on. And my hope is to develop a large-scale registry study of non-operative AIS care. Thank you for your time, and I'd be happy to take any questions.
Thank you, Dr. Baldwin. That's a monumental task that you've undertaken, I believe, and good progress considering everything that's involved. I'm just to start it off, I'm curious about logistics. At the end of the day, what were the person hours that it took to get this off of the ground? You talked about data use agreements and IRB, and there was, I'm sure, considerable communication in the beginning between groups to get this going. So what is the effort that's required, and is this creating templates that will be useful for other multi-site studies going forward?
You mean like to add sites? Is that what you're referring to? Yeah.
Yes. Right, because you want to get to 5,000, right?
Yeah, I mean that's the goal, and ultimately I think when you start out doing a study like this, whether it's prospective or retrospective, I think one of the key things to do is to create a data dictionary, so that different sites can be collecting the same data as you are. And so that was the first thing that we had to do in order to make sure that each site, study coordinators are sort of collecting the same data, because obviously you want to compare apples to apples, and obviously that requires some person hours on our part, and also I think after that data dictionary is created, sending it out to the sites, and just making sure that there is consensus among the sites that we're collecting the right data. I think the other thing that's might present a challenge in the future is just dropouts of patients, because I think the patients that are being followed in braces are probably more likely to follow up, but some of the more what you say minor curves might be a little bit less willing to follow up, and I think that's one of the things that worries me the most about it. And I think I want to make sure that everything is that we need to collect at the point of service is collected, so that you have that framework going forward and you can follow those patients and know what they were when you first saw them. Later on, I think there's going to be other data that's going to be collected, curve apex and that sort of thing, that is present on the initial x-ray that you don't really need to worry about quite as much. This group did do a couple of survey studies that were sent out to a bunch of different organizations to try to figure out what was important to people to collect. And the hope is that we can sort of spread this to as many institutions as possible, because I think just in terms of understanding risk factors for progression is super important when you're talking about things like bracing and tethering and physical therapy for scoliosis. You want to be able to select a group that's highly at risk so that their chances of progressing to surgery is like high enough that you don't need like 1,000 patients to like collect everybody. You just need to collect the at-risk group. And that's the hope with this study.
You referred to this as a Framingham study, potential Framingham study for scoliosis. Are you envisioning that this will extend into adult-based studies? So have your patients consented for their data to be used long-term? And is it data that one could use in future following these patients to see complications of scoliosis in adulthood?
Long-term, yeah. I mean, I would hope that would be the case. I think some of the things that you find like in the Framingham study were very valuable because they collected for patients for like 40 years. And you don't expect that all these patients are going to be available after 40 years to follow up. But I think in the future, as long as you have their baseline, I don't know that they've consented for long-term follow-up for that sort of thing. But I think that's definitely something that you can consent them for like in the future, assuming that you have their initial data. The whole key is to have their initial data and have very good initial data in a sense for when they were found. And that was what the initial retrospective study I think was a little bit weak on, and that's why I'm hopeful that this study will sort of repair that issue.
We have a few questions that have populated. One from Dr. Tesakova. Thank you for your research! Exclamation points. Do you take into account RISR testing routinely, and particularly as some clinics do not do Sanders testing routinely?
Yeah, I think we chose to do the Sanders score because of data that showed that it tracked a lot better with skeletal maturity. I think RISR scores are something that usually are visible on a lot of spine x-rays. So I think that's something that we could go back and look at in the future if we wanted to, particularly if you had a group where there was like 5,000 patients. Like I said, my concern was, adding too much of a burden on research coordinators for patients that may or may not follow up. I think, as a group, I think we've decided to sort of come up with a larger data set for patients that have actually made it through the study. Based on information that we already have, either through the electronic medical record or the initial radiographs.
Thank you. We have an additional question, a couple more questions in the chat from Dr. Pausius. I hope I'm pronouncing that correctly. Important work, congratulations. Have you made any modifications to the protocol or study intentions since inception and initial enrollment? How many factors would be reliably able to be considered with the projected sample size? And I guess projected to 500.
Yeah, I mean that's the issue. I mean, as you if you noticed in the initial table, there was only four boxes and 4 boxes. So the more boxes that you have, the less power you have per box. And so whereas there's like 8 stages of Sanders, we only had 4. And that's because that creates more power within each box at the expense of some information. And so obviously with 500 patients is going to be similar power to what we had in the initial work that was retrospective. Only we might cut down a little bit of the variance because our x-rays are going to be better, and our information is going to be more streamlined. That's what you get out of a prospective study. I think with 5,000 patients, hopefully you have 10 times as many in each box. And so you could really drill down to different things. Like you could drill down to, apex of the curve, or whether it was a thoracic or lumbar curve, or, different disease factors that's specific to the patient. I think those things add power. So you add power incrementally, but the problem is you just need so many patients for that. I think with something like AIS, particularly given that 95% plus are going to be patients that are non-operative, I think it affords you the ability to get that type of power, though. And really, that's this is why I kind of framed it as a Framingham study, because it's really kind of a similarly very prevalent thing that you can follow for a long period of time and really figure out, like, are these things that matter long term, or are they not, and should we be thinking about different treatments that can modify the disease?
That's such an important point. You want to gather every variable, but it's a trade-off with power in any study. Good point. Another question from Dr. Michelle Marks. Dr. Baldwin, have you considered telehealth visits for longer term follow-up to increase your potential follow-up rates?
Yeah, we haven't really gotten there yet. I think that is definitely, like, if we were going to do long-term follow, like really long-term follow-up, like 10 or 20 years, I think that would be definitely something that we could do. One of the issue, it's actually kind of a funny question, because we tried to do a randomized trial of telemedicine for following, minor curves, like 10 to 25 degrees, ones that we weren't bracing, to see if there was like an increase in patient satisfaction. We did that at CHOP, and the project totally failed. And it was interesting because we couldn't get anybody to come into the telehealth arm, because everybody was like, yeah, I'm already there for an x-ray. Let me just I'll just get seen while I'm there. So it was very difficult to recruit for that. I think, like, it may become different if your patients go all over. And then I think another thing that is a challenge for longer term follow-up, it might be a little bit less of a challenge for a research study, but for actual medical care, if the patient moves to a different state, you're not licensed in that state, all of a sudden you can't really follow them. So you can get an x-ray for research purposes, but you can't really tell them anything based on their medical care, because you're not licensed in that state. So there are definitely multiple issues that need to be addressed.
Thank you. And I think one last question from Dr. Beji. Thank you for your presentation. Do you consider the flexibility of the curve as one of those risk factors by bending X-rays? And part two of this question is, does the brace design in all centers, is the brace design in all centers similar?
Yeah, so as far as the flexibility studies, interestingly, we that was one of the questions that we asked, like, for our survey studies and we got something like 140 responses, and because most people don't get flexibility studies except for at the very end when they're considering surgery, that was not considered to be a standard of care thing, and so it would have required a lot heavier a lift on the IRB end. And whereas I agree that it's important, particularly for the larger curves, we did not do it for that reason. And as far as the brace design, so even within our own institution, there are different brace designs, and that is like kind of one of the crosstabs that we hope to look at in the future. Is there actually a difference between brace designs? One of our clinicians really likes to use a Rigo brace, and the rest of us kind of use a more typical Boston brace. And then some of the other centers use something that's a little bit similar to the Rigo brace, and then some of them use Boston brace. So there are some differences in the brace design aspect of things that I think can be sort of hashed out with crosstabs at a later date.
Thank you very much. And with that, I believe we have come to the end of our symposium. I want to encourage everyone to remember to take the survey, and I'll say this again at the end. when you get off at the end of this, please remember to take the survey and let us know what you think of the symposium. I want to congratulate all the speakers on excellent presentations, very clear. Everyone was here on time. Your slides were excellent, and I think we all learned a tremendous amount. I am personally really excited by the rigor of the presentations that you heard this morning. We heard several prospective studies, and in my opinion, that's a big advance. It's something that has been, we've been trying to generate in the scoliosis field for quite some time. So congratulations to all of you who are putting together these very powerful prospective studies. The complementing that are the animal basic research studies that, again, I think are being led in a very rigorous way, and we heard that this morning. And the imaging modalities and the measurements that all of the researchers are applying are cutting edge, and I'm sure going to be quite informative. And then just the applications of new technologies is really exciting to see as applied to our scoliosis research. So congratulations to all of you, and best of luck going forward. I also, as I said earlier, appreciate your honesty in your presentations and letting us know what the pitfalls are. That's a major point of this symposium, is to help teach us all how to overcome challenges in our research. And then finally, thank you again to the staff, Laura and Sean, for all the hard work and for leading us in this symposium this morning. Couldn't do it without you. So again, thanks to everyone who participated. Thanks to all of you in the audience. Thanks for very creative and thoughtful questions. Thanks everyone. And I think this closes our symposium.